Welcome to the New Retina Radio Journal Club with VBS. My name is Ben Young from the Casey Institute with OHSU in Oregon. I'm joined today by Phoebe Mellen from Retina Vitreous Consultants in Pittsburgh. Hi, Phoebe.
Hi, Ben. Thanks for having me.
And Jordan Diener from the Wills Eye Hospital in Philadelphia. Hey, Jordan.
Hey, Ben. Thanks for having me.
Yeah, thanks both of you for having the time to talk about this interesting and I think really important paper that's titled Diabetic Retinopathy Disease Burden in Patients with Lower Household Incomes versus Higher Household Incomes. The first author was Hemal Patel, and this was published in the Journal of Vitreoretinal Disease in January 2025. So, Phoebe, I'll throw this to you first to kind of just summarize the findings of the paper.
Thanks, Ben. So the purpose of this paper is to assess the differences in diabetic retinopathy disease burden between high-income zip codes and low-income zip codes at presentation to a retina specialist. Specifically, it was a retrospective single-center observational study looking at patients with type 2 diabetes evaluated by doctors at Duke Eye Center Retina Service from 2014 to 2023. So the investigators performed a retrospective chart review using the Clarity database at Duke Eye Center. Patients were initially identified using type 2 diabetes codes to determine which patients had retinopathy present. Those with concurrent eye disease, such as RVO and AMD, were notably excluded from the study. The demographics for these patients were then also collected on each patient. The zip codes of their home address were then matched with the U.S. Census Bureau's 2020 median household income data by zip code of residence. Using the U.S. Census Bureau's median household income data, patients were then broken into quartiles based on their median zip code income. So researchers compared patients in the top quartile zip codes, which was labeled the high income group, with the bottom quartile zip codes, which was labeled the low income group. In total, there were 430 eyes in the study and 215 patients. The high income group included 196 eyes in 98 patients, while the low income group was 234 eyes in 117 patients. So let's take a look at the findings now. We're going to go ahead and compare the high income diabetic retinopathy patients with the low income diabetic retinopathy patients on a few measures that they were looking at. First, in terms of demographics, the mean household income for the high income patients was about $101,000 versus the low income patients was on average about $48,000 per year. The patients in the high income group were most likely to be white, and the patients in the low income group were most likely to be Black. So now we'll take a closer look at the diabetic retinopathy disease burden in each of these two groups at presentation. So the patients in the high income group, 32% presented with mild NPDR versus only 9% of the low-income group presented with mild NPDR on presentation. And comparing this to severe NPDR, for instance, only 13% of the high-income group presented with severe NPDR versus the low-income group had 24% with severe NPDR. This is almost twice as much as the low-income group for the stage of retinopathy. Similarly, looking at the PDR rate, only 14% of the high-income group presented with PDR at their initial presentation versus the low-income subset of patients had a PDR rate of about 31%. In terms of diabetic macular edema, the high-income group had a 57% rate of diabetic macular edema at presentation versus the low-income group had 77% of patients had diabetic macular edema. In conclusion, patients in low-income zip codes were at significantly higher risk for PDR, DME, more severe NPDR, and a need for intervention compared with patients from high-income zip codes at the time of presentation to a retina clinic.
Great. Thanks, Phoebe, for giving us a really good summary of a very statistically complex paper. Jordan, let's start with you. What initial reactions to the findings from this paper?
Thanks, Ben, and great summary, Phoebe. But I like this paper a lot. I think that it is very well thought out and executed. I really loved one of the author's conclusion lines. They state that social conditions fundamentally drive health inequality. And I think that's just such an important statement. And I think we as a whole practicing specialty underestimate how much social determinants of health affect the severity of patients' disease, not only their presentation, but ultimately their outcomes and their prognosis. As the author suggests, I think this probably goes well beyond household income as they presented in the study, and that lower household income is probably also likely associated with other factors that are associated to more severe disease, such as lower education, poor diet, limited ability to access, lack of access to more advanced diabetes medications, and lack of transport, maybe to multiple doctor's appointments. Um, I think the only other thing I would talk about is that this data definitely seems to match kind of what I see in clinic, especially at Wills Eye and Center City, treating an urban underserved population. I see a number of young patients who are uninsured, suggesting a lower income, who present with the first episode of vitreous hemorrhage as the first sign of their proliferative disease, who didn't realize they even had a problem until they couldn't see. And when I compare that to some of my peripheral offices in more well-to-do areas, I tend to see lots of diabetic screenings with minimal or no disease, and very, very rarely do I have someone come in with a dense vitreous hemorrhage or a tractional retinal detachment.
Yeah, no, I mean, definitely a lot of this I think rings true with what a lot of us see. Phoebe, what do you think? Any like kind of quick takeaways from the paper to start with?
Yeah, Jordan touched on it really nicely. I think that this is a very complex topic with so many different social determinants at play here. And when we think about our patients, I think we can't just think about the fundus photo or the angiogram and here's the diagnosis and here's how we treat X diagnosis. But we really have to take the full picture into view and understand kind of where the patient's coming from in terms of what barriers they have to coming back to clinic, what other things are going on in their life. And oftentimes these diabetics are very complex and have other physicians that they need to see, which not only is time, but that's travel, that's copays, things like that. That's time off of work. So I think having an understanding of kind of the whole picture of the patient is really important. I think that's really highlighted in this paper.
Great. Yeah. Thanks, both of you, for kind of summarizing some takeaways. We are going to definitely do a much deeper dive into this paper right after we come back from the break. So everyone, hopefully, please stay tuned. And welcome back to the New Retina Radio Journal Club of VBS. So let's get into a longer discussion now about the paper that Dr. Millen just summarized in the first part of this episode. So when I read this paper, I wondered how would this affect my clinical practice, having this important data available to me. And one question that immediately springs to mind is, would knowing a patient's income status change how I treat them, or should it change how I treat them? So Phoebe, maybe I'll start with you. Let's take kind of like a common scenario. You've identified a patient with PDR, and I think all of us know or agree our first choice is either probably PRP or injections with anti-VEGF agents. Does a patient's income status affect, or should it affect how you decide which strategy you pursue?
Thanks, Ben. So no, I don't think a patient's income status or zip code should affect how you treat a patient. That being said, when a patient comes in for the first time with PDR, vitreous hemorrhage, I try to have a really frank conversation up front about the state of their disease, how advanced it is, and then what's going to be required to fix them or improve them or stabilize them. And patients, I try to say, I'm going to need to see you every month. We can do injections, we can do lasers, and we're going to make a lot of improvement. But I try to be very upfront about the treatment burden, how often I'm going to need to see them. And then that's a time for us to have a very candid discussion about the other barriers to care. Can they come every month? Are they going to need time off of work? What are their other barriers that prevent them to coming to see me? And then we ultimately, that helps to inform the decision of what we're going to do. A patient who I may have been seeing very frequently for screening diabetic eye exams, I may choose, and they've proven to be very compliant, I may choose to start with anti-VEGF and then slowly add in PRP over time versus someone who has either been non-compliant in the past or I have concerns about their ability to follow up. I may start PRP sooner and try to put in more upfront to try to stabilize them quickly. So if they're lost to follow up, we can try to make progress on that front as much as we can.
Yeah, great. I mean, I think it's very reasonable. Jordan, what do you think? Or maybe I'll add another spin to it. Do you think the EMR should add a flag, or would it be helpful if the EMR added a flag that said, hey, this patient comes from an area where maybe lower socioeconomic status? Would that help at all in you synthesizing what a patient might need or what's the best treatment strategy for them?
I think it's an interesting idea. I'm probably pretty 50-50 on it. I would say we'd have to be very cautious. If we implement it, we need to use it with caution. I think we have to treat patients as individuals. And so just because someone comes from a low income zip code doesn't mean they necessarily have low income, and kind of vice versa, right? Just because someone comes from a nice neighborhood doesn't mean they might not have other or their own socioeconomic barriers to healthcare. And so I think treating individuals is the correct answer here. And I really don't talk about income, but of course, if financial barriers arise in our discussion of treatment, then we have to really think about it. Phoebe kind of already described our hypothetical patient, our young patient with PDR and advanced disease that shows up and has not yet established kind of that they're going to come back and continue with care. One thing, if the patients are uninsured or can't pay for things, I always think the laser is very low cost and even no cost sometimes. And I'm pretty quick to give out PRP to these patients because I think the worst thing we can do is say, see you later, or have them get lost to follow up. And then they come back 6 months, a year later, and they have one or both eyes have bilateral TRDs. And then we're both sad. And that's a huge burden on our health system. That's a lot of financial things that have to then be paid for either by the patient or by us or both. And so sometimes I think really taking that into consideration and getting them the therapy that they need in advance is important.
And Jordan, I also want to come back to something you alluded to kind of the first half of the episode, which was that this income status is one thing, but it's not like everything in terms of representing why these patients may have worse diabetes when they show up. Do you want to talk about some of the other factors that might influence a patient with perhaps lower socioeconomic status and their diabetic disease?
Yeah, I mean, I think we have to think about patients that come from lower socioeconomic status. Again, it's on an individual basis, so we can't presume this about everybody, but there are other studies out there that connect it to lower education. There are other studies that connect it to need for public transportation to get around. There are other studies that connect it to loss to follow up or just not following up as much with their endocrinologist or their diabetes doctor to make sure that they are getting the correct diabetes medication and the care they need. And I think that all leads to worse disease care. It leads to probably not going to all of the screening referrals that you need to go to be screened and catch this diabetic retinopathy early. I think this is kind of a snowball effect. And so I love this study. I think it's a great high level insight into what's going on. But I think probably if we look at this closer, there's some other confounding variables here that are probably more key factors than just a money thing here.
Yeah, yeah, and like I think one of the things that I've just started noticing in my practice is what tends to be if a patient's diabetic, they may have family members who are also diabetic or have poorer health,
Mhm.
and they may have to take care of them, make it harder for them to get access to care. Phoebe, one thing I wanted to ask or bring up with you is that the study, the data set is really all kind of from one part of North Carolina in the area of the Duke Eye Center. What do you think about, do you think that this will generalize if the study was expanded, or do you think things might actually look worse than the data that we have here? Do you think that's a significant limitation, the regional aspect of the data analysis?
I think that this does speak to kind of one area, as you mentioned, and those probably specific to those zip codes, specifically when it comes to median income and the racial differences. However, I think if you were to look at the total United States, I think probably the disease severity may trend to be similar. And the reason I say that is just that there's been other studies that have, like Jordan mentioned, have kind of correlated the socioeconomic barriers with disease burden. So I think in general, I would expect them to be fairly similar. Anecdotally, from my experience in a few of my offices where access to care may be a little bit limited, I do have this where I feel like some patients do come in with more severe disease coming from farther away, coming from hours away, where it's challenging to get them to a retina specialist. I may be the only retina specialist for a few hours. And I do see this. And I think that really one thing that I wanted to highlight about this paper is the importance of screening. And so when I look at the statistics, when I see that the high income zip codes have mild NPDR making up the majority of their percentage of upon presentation, what that tells me is those patients are getting their annual diabetic screening eye exams. And because they're asymptomatic for the most part, unless of course they have DME. But a lot of those patients are going to be asymptomatic, whereas the lower income patients aren't coming in until they're symptomatic of a vitreous hemorrhage or of DME, vision loss, things like that. So the one thing that this also really highlights for me is improving access to screening, whether that's in a primary care doctor's office, telemedicine, optometry visits, things like that, to get these patients in the door and screened as soon as possible and making that a bit more accessible.
Yeah, that also reminds me. There's one patient that I had seen. I'll keep it kind of anonymous at some point in my medical journey where I remember I diagnosed him with PDR and they ended up calling the primary care doctor to kind of update them, and there were other things that had to be done for that specific patient. And I tried to point out, hey, you primary care doctor had seen this patient for many years and knew they had diabetes, and they were never referred to an eye doctor. And primary care doctor said, "Oh, I didn't know you guys could do anything about diabetic retinopathy. I didn't know there was a point." And I don't mean to primary care doctors have so much to deal with, so many things to know, and it's so many things to keep up with. But I think part of the takeaway maybe from this paper is, like we've been saying, maybe it doesn't have to directly affect our practice. We don't have to judge people differently based on their income status, but in terms of a public health perspective, raising awareness, improving the access to care from the entry level, like we're saying, Phoebe, I think would be a great takeaway for the healthcare system. Yeah. So Jordan, I don't know if you have any maybe closing thoughts on screening and what this paper means for that.
Uh, I guess, Ben, I think one of the most outstanding findings I thought in this paper was that the low income patients that presented with more advanced DR, despite controlling for the hemoglobin A1C, it really suggests delayed access. We're not getting these people in to see ophthalmologists. It's not just poor diabetes care. And so we really need to figure out a way to see why these patients aren't going to see their ophthalmologist sooner and screen this population better. And perhaps this is a great place for telescreening, perhaps with the addition of AI to supplement our care in these low-income populations. Perhaps this is an opportunity for us to educate our primary care doctors and our endocrinologists about the need for screening for diabetic retinopathy. Maybe their referral thresholds are higher, or maybe they're biased in this population, maybe due to their incorrect education about the ocular disease. Maybe it's an insurance issue. Maybe it's travel. Phoebe talked about patients traveling hours to see a retina specialist. Maybe it's something as simple as just having appointment availability or access to care. But we certainly need to do a better job of screening this population earlier. That is the number one thing I took away from this paper.
And I think it's a great takeaway to close the episode with. Phoebe, Jordan, thanks for coming on and sharing your thoughts about, I think, this really important paper. And I'd like to thank the audience for listening to the new Retina Radio Journal Club of VBS. And I hope you stay tuned for future episodes.